Thank you very much, Maury, for that tour de force. One of the practical challenges that comes up for all of us is the issue of credentialing and the realities of turf wars, as Maury alluded to at the end of his talk. There's been a lot of focus on this just in the last couple of years, as many of you are aware, with the combined statement from the gastroenterologic societies and the American Board of Surgery response to that. So I wanted to have one of the things we at least alluded to in the postgraduate course today is just that issue of credentialing realities and endoscopic skill. Are we really training our residents for the real world in our surgical endoscopy training programs and protocols? I'm going to invite one of my colleagues at SIU, Imran Hassan, a colorectal surgeon who's done a lot of work with our residents and training in endoscopy to address that topic for us. Imran?
Thanks, John. Good morning, everybody. So basically today I'm going to talk about credentialing and training for endoscopy and the realities about it and how it relates to competency in endoscopy. There are no is it still this one? Okay, yep, okay, sorry. All right, no disclosures. So endoscopy in general surgery practice is one of the most common procedures done, as Dr. Finlayson alluded in the initial talk. And I won't go into that in more detail, but that's just the current state of affairs. But in the future, this is going to get even more demanding, and this is just one angle or one aspect of it, that if you look at the current workforce available for endoscopy, we have general surgeons, we have gastroenterologists, and we have colorectal surgeons, and general surgeons make the bulk of this workforce. If you look at the number of Americans above the age of 50 who need screening colonoscopy, and you do the math of everybody being screened every 10 years, that's about 200 colonoscopies a year, which in itself is not a daunting number, but this is just for colonoscopy for screening. If you add in all the other endoscopies, all the other reasons to do colonoscopies, that number kind of exponentially gets bigger and bigger. And if you kind of just for 200, if you drop out the general surgery workforce, that triples the load on gastroenterologists. So the reality is that surgeons will do endoscopy, and they have to do it well. The question is, how do we make sure that the people who are doing endoscopy are adequately trained and competent to do the procedure? Now, if you look through the literature, there are several position statements from different societies that kind of give the guidelines of how to credential endoscopists and trainees. And more or less, they're relatively vague, but they kind of go around the same theme, that endoscopies should be performed by endoscopists who are competent, but they really don't give out a number of what the magic number is that they need to achieve, but they more or less just stop short of saying that they have to be competent and they need to use objective criteria of how to determine that this competency exists. And that's kind of useful because almost 50% of the endoscopy centers in the United States that were surveyed not even require a number to allow endoscopy to be done. All they require is that they have some documentation that they're competent to perform endoscopy. In the same document, they kind of talk about how do you determine competence, and they more or less put the onus on the training programs for general surgery and for gastroenterology, that when they go through this program to get trained, by the time when they come out, they will be competent to perform endoscopy. So therefore, the way between the credentialing documentation and what the expectations are, that endoscopy requires the endoscopist to be competent, and the onus to make competent endoscopists fall on the training programs. The million-dollar question, or question in this case, is that how do we measure competency, and then the second part of the same question is how do we achieve it? And that's where the dilemma lies. Currently in the United States, there are about 1,400 that's one extra zero. There are 1,400 gastroenterology fellows and general surgeons, of which about 1,000 to 1,100 are general surgery residents, and the rest are GI fellows who graduate each year in training programs. And the common goal for each of the training program is to train competent endoscopists who can perform the basic skills, the basic cognitive skills and technical skills of endoscopy. However, the pathways to achieve this common goal are fairly diverse. And this slide, there's a lot of alphabets and I had a lot of numbers. And the numbers vary from 142 colonoscopies to 50 colonoscopies for the RRC, and then the American Academy of Family Physicians don't even give a number, they just say they have to be competent. So the whole endpoint or the benchmark is fairly broadly spread. So the question is what benchmark or what endpoint we use. So we know what competence is. It's the ability to perform a skill, and endoscopic competence or competency in endoscopy relates to performing an endoscopy. It's the technical aspect, and then the cognitive aspect of knowing when to do it. However, the pitfall in endoscopic competence that has come across over the years is there are no objective measures how to measure the technical skills and cognitive skills in endoscopy. As a result, the competence has been based on numbers, and the number of endoscopies have been used as a surrogate to determine competence, which in reality at the time seemed a good idea, but over time this has borne out not to be the best endpoint to use. And then the question arises, how did we come up with this number? And as the facts are, it has to be based upon some data. So there's a whole body of literature published on how the number is determined and what is the right number. And these are just some of the papers that are probably most commonly quoted and based upon which the position statements that have been made from the various organizations allude to. But the key thing to point out is that all of these papers are almost 10 years to 15 years old, and a lot has changed in the last 10 to 15 years. The limitations of the data that was been presented so far, which is the old data, mainly relate to the endpoints they used to measure a successful endoscopy, which is basically cecal intubation, and then the sample sizes and other methodological difficulties in the study analysis of how they came across those final numbers. Now, cell phones in the last 15 years have made a lot of improvements. So the question is, have we made any improvements in evaluating colonoscopic performance? And I'm going to give a few papers in the literature in the last couple of years that kind of shown some progress, but still probably don't exactly hit the mark or show where we need to be. This paper is out from Rochester that looked at 3 years of data from GI fellows that trained starting as first years and finally graduated. And the number that they came up for achieving competence was around about 275 using a validated tool. This paper out of Wisconsin kind of did the same thing in their group of GI fellows. However, the number that they in the end came up with was around about 500. And then the last paper, which is a combination of GI docs and surgeons, kind of try to determine the number of where proficiency would be achieved, not necessarily competence, and the number that was quoted in that paper is around about 75. So the strengths of the studies that have been published more recently is that they've used validated tools and used more objective benchmark measures to measure competency. However, there are still some limitations, in particular the external validity of the data in terms that most of these were done in GI fellows, and the question is how applicable is that to surgeons in general. So as we talked about, the mark is all over the place. We start from 75 to almost 500, and that more or less was the title of one of the editorials of one of these papers, that where does the sweet spot for colonoscopy competence exist? Is it 100 or 500 or somewhere in between? Regardless of where that sweet spot is, the reality is that right now, for the general surgery residents that we train, we're probably not doing a very good job. This paper is from Dick Bell that was published a couple of years ago, and the mode for colonoscopies for graduating surgical residents was 0. That means that was the most common number documented. And even if you go by mean and median, those numbers are far below any benchmark that has been published so far. And at the same time, when in another survey, at this point, only 2/3 of the programs in this country have formal training curriculums for endoscopy, and only 1/3 are led by fellowship-trained instructors. So if we ask ourselves the question again, are we training our residents for the real world? The answer probably is no, and there is a long way ahead of us in terms of what we need to achieve. And the next few talks hopefully will kind of outline that, but the key point or the next two challenges would be to have standardized curricula in terms of how to train residents and how to train endoscopy. And then beyond just measuring numbers, there need to be more objective measures of measuring competence in endoscopy. Thank you.